Hello, everybody. My name is Kris Abbas. I'm an assistant professor at the Department of Anesthesia at McMaster University. I have actually done my anesthesia training in Belgium, so I have long European roots when it comes to my education. So I would like to thank the organizers for giving me the opportunity just to talk a little bit about the main issue when it comes specifically for anesthesiologists. I'm not quite sure if some of the attendees are anesthesiologists or not, but I'm quite sure other people from anesthesia will probably know about this type of information. So I'm just going to take the time for the next 15 minutes just to summarize a couple of important articles published by the American Society of Regional Anesthesia when it comes to establishing guidelines for training and education. Sorry, just trying. Here we go. So I don't have any financial disclosures. I did in the past, did consult before my residency time for ultrasound companies. But for the past few years, I've been focused on the training and, to kind of improve myself from a clinical aspect and ultrasound aspect as well for my practice. So I've listened to the last couple of presentations, and it seems like the group is very well-rounded when it comes to the use of ultrasound in their practice. So some of this information might be a little bit kind of known to most attendees, but POCUS basically is just stands for point-of-care ultrasound. It's basically defined the use of ultrasound, bedside ultrasound, to help in decision-making, just as an adjunct to your clinical assessments when you have some certain situations when you're not very sure about what you're supposed to do. So ultrasound can help a little bit in making that decision a little bit easier. So in recent years, technology definitely has improved a lot when it came to ultrasound. I was blessed to right out of med school to work with a group that was very interested in ultrasound applications in anesthesia, specifically in regional anesthesia and pain, chronic pain applications. And back then, I remember, the ultrasound machines were quite large, and if you go with anything small, the image quality was not that great. Obviously, things have changed in the past decade or so. Ultrasound companies are competing nowadays with their technology and for image acquisition, making the devices smaller to the point nowadays that we have handheld devices that are a lot obviously cheaper for the user, just for quick testing to use. I wouldn't depend on it for full assessment, proper assessment for patients that require full sonographic assessment, for cardiac purposes, obviously. The use of ultrasound for the past few years, obviously there's an overlap in the subspecialties, in anesthesia, for example, between cardiac anesthesiologists, intensivists, regional anesthesiologists, and pain physicians. There's a diversity in clinical ultrasound applications amongst all these specialties. Since I'm from Canada, obviously we're always interested a little bit in knowing what's happening in North America when it comes to recommendations. So the American Medical Associations has a recommendation about the policy for the ultrasound imaging, for the criteria granting the ultrasound privileges for physicians, as long as these criteria are met and in accordance with the recommendation for the standard of education and for each subspecialty, basically. Our interest, because the reason I chose this type of talk to summarize both articles that are published basically by the American Society of Regional Anesthesia for two reasons. One, I'm an anesthesiologist, and two, I'm a regional anesthesiologist, one of the subspecialties that I've chosen. After I finished my training in Belgium, I came and I've done two fellowships, one of which was the actual regional anesthesia and the other one was POCUS. So obviously my interests are in those two applications and to help other physicians to acquire the knowledge and the skill set to be able to use this type of application in their daily practice. So the aim of the American Society of Regional Anesthesia basically was to create a task force which their main goal was to provide alignment between the regional anesthesiologists and pain physicians for training recommendations in the perioperative setting. So they created the task force basically, and the task force had the job was to try to research published articles and provide communication amongst certain subspecialty groups from regional anesthesiologists who have interest in other applications of ultrasound, or as I like to call them, emerging applications at that point. And to be able to choose a panel of experts and groups that the experts can lead basically in providing proper education, and the task force basic recommendations was to outline the clinical indications for POCUS application and to define specific criteria for education and competence to establish a competency and credentialing for those type of subgroups like regional anesthesiologists or chronic pain. And the reason they chose that is because for the past few years, the past couple of decades or so, regional anesthesiologists and chronic pain physicians have been using ultrasound in the daily practice. So the knowledge of started with basic ultrasound and became moderate. Some people became experts in that field. And their understanding of the basics of ultrasound was imperative, obviously, to try to take on different applications. As I mentioned before, the emerging applications such as gastric ultrasound, for example, still requires you to have good knowledge of fundamentals of ultrasound. So after the task force was formed and the experts were chosen, obviously they created the panel. And the panel was made of national, North American, international experts. Some are actually from Europe, from Asia and South America. So they have experts from around the world to help assess in their programs around these different corners of the world to create these programs. And the panel selection was obviously was not easy. It took time to make sure that you're choosing the right people for the right job. So they had to depend on publications done about POCUS applications, which I will go through in a minute. To choose proper leadership, as I said, people with expertise in regional anesthesia and pain medicine, again, just because of the knowledge of ultrasound that they have. And to ensure all the topics were accurately covered as well and appropriate for education and training recommended by the ASRA task force. Competency, to establish competency, and how do we say that this anesthesiologist is competent enough to provide such clinical examination with ultrasound. Again, this was done through research, published articles, and systemic literature research, basically clinical indications that were done for POCUS for anesthesiologists. Some of the recommendations were drawn for subspecialties were taken from some specialties that already had some guidelines established for years, such as emergency medicine, surgery, radiology, cardiology. So they had to use these guidelines, skeletons, basically, to try to build our own skeleton in ASRA. And these corresponding groups were tasked also describing the educational goals and requirements for the competency for the regional anesthesiologists and pain physicians. Obviously, this takes a bit of time. It does not happen overnight, so obviously it took time, for through the leadership of these groups to contribute, and the authors also had access to all these documents to either adjust or add to it or improve over a certain amount of time. So what are the POCUS applications? Many of you are aware already. There are emerging applications, and apart from the regional anesthesia, since regional anesthesia, ultrasound and regional anesthesia started, I would say, from early 2000s onwards, and every year or every month, I would say, there's new approaches to certain things. Some of the regional anesthesiologists, I'm one of those people that took interest in learning other things rather than just regional anesthesia that can help me in my daily practice, from basic cardiac exams, lung ultrasound, airway, gastric, and obviously FAST, which is already established in emergency medicine, but we do apply since we are considered critical care physicians. So the recommendations that were done for the by the task force and the ASRA in the published two-part article basically recommends that every person who's interested in doing POCUS should have the basic fundamentals understanding of the physics of ultrasound and the equipment that you're going to be using, how to operate it, and how to utilize the best way of using certain probes for your application, the different type of applications. It's imperative to have this type of knowledge. Otherwise, acquiring an image and not being able to interpret this is just going to be kind of time wasting. They also looked at creating kind of a baseline to learn the difference between basic POCUS ultrasound examination, advanced knowledge as well. So knowing the difference between the probes, as I mentioned, whether it's linear curved or phase array probe, and the latest technology that came out right now, just the way they build the probes, the newer probes right now, it's called CMUTs. To keep up with the technology as well, because technology is always ever changing, and to be on the train of learning these type of new things on daily basis that can make your life a lot easier in your application. This is basically kind of the summary that they have in the first article that they have from ASRA that was published in 2021. In part one of the article, they basically summarize the kind of knowledge that you might need to gain as a basic knowledge of ultrasound, physics and equipment, for learning certain wording in the ultrasound physics, from amplitude, wavelength, frequency, all that stuff. I'm sure most of you already are familiar with. Certain types of artifacts and what you can do about these artifacts, the equipment, what kind of probes that you use, the machine that you use, and the knobology, as I like to call it, what kind of buttons you need to know to be able to do your ultrasound examination. So they have obviously found some benefits from using the ultrasound in their POCUS application, and some challenges as well. I'm sorry, I'm just trying in here to minimize that screen so I can see. Okay, so the benefits of POCUS have been widely advocated by many subspecialties. There's a plethora of publications in the past few years about the positive impact of POCUS application for decision making. But the challenges are POCUS has been used obviously as a diagnostic tool or a monitoring tool, but it's very hard to do randomized controlled clinical trials that can actually show that POCUS does have a very high impact in your decision making. This is basically on in clinical application and the peer review by doctors on clinical scenarios on daily practice. But to kind of establish a research project, which basically can be a randomized controlled trial, whether to use POCUS or not to use POCUS for your clinical decision making, would be a little bit challenging for that. If you don't have, obviously one of the challenges, if you don't have enough or proper training when it comes to POCUS, and you're not competent enough, that can also make your decisions, either you overdiagnose or overtreat a patient, or potentially just cause some sort of injury during your scans. You have to be competent. You have to go to certain courses. You have to do your due diligence when it comes to learning these type of skill sets. So obviously, it's operator dependent, and anything that you do, especially when it comes to ultrasound, is operator dependent. Some are a little bit better than others, but because of that reason, ASRA started looking at standardizing the training, basically for physicians who are interested in POCUS. The technology, as I mentioned previously, is improving dramatically. There are, in the past, now things are getting a little bit better when it comes to the technology. In the past, with bigger machines, it's very hard to get the machine around, the boot up time. There was a lot of issues that you had to overcome to try to do a quick POCUS exam. Nowadays, as I said, we have the handheld devices. There are multiple companies that do that, between GE, Philips, Claris. There's multiple companies that created the handheld ones. How to choose one, of course, is a matter of preference from one physician to another, what they're looking for. Obviously, handheld devices are not going to be able to provide you with every single feature a big machine can have, because that requires, obviously, a proper computing system and storage that would help the device to store and analyze and give you all these features that you can do. But handheld devices are great in terms of doing your quick POCUS examination, and for learning and for teaching at the same time, for future physicians or physicians-to-be. So they summarize in their article in here basically the advantages, disadvantages. As I said, it helps the ease of transport for the handheld or smaller devices, if you will. There are laptop designs as well that are much easier to move around. They're much easier to boot up. Most of them have Wi-Fi technology that you can basically upload your images without actually plugging it into an Ethernet cable, for example, or having to store the images onto a USB. Most of these companies with handheld devices, the ones that look like a regular phone, basically has Wi-Fi that you can upload to a possible cloud service if you don't have one. Limitations for those, of course, are not going to be as great in terms of features. Battery life, of course. I'm not saying that you have to charge it constantly, but you don't expect, obviously, a handheld device would last as long as a machine that is either plugged on the wall or has a much larger lithium battery, for example. The other issues, of course, that hospitals may always come and ask for, to make sure that you are abiding by the safety of information. You're not exposing any patients to any leak of their personal data. Is that cloud safe? The cloud service provided by the company, is it saved? Is it what we call here in North America HIPAA approved? And of course, the sterility concern. These type of devices, when you have them sitting in a machine, in a room, in a big machine sitting in a room, you do your examination and you can take a surface cleaner, of course, and you have to take care of the machine and you wipe it off and clean. Handheld devices will depend, obviously, on the user. It's like carrying your own stethoscope. If you don't clean it after use, you're putting yourself and your patients at risk of contamination. So the second part of that article basically just kind of revised what they had in the first publication. They emphasized on the multiple groups that were established by the ASRA task force, where they had to go through the education again, went through the ultrasound physics, the image interpretation and image acquisition, the technology to facilitate the training. Is it available in every hospital, training university hospital or not? The interactive computer-based modules that learners can use to learn Not everything has to be hands-on. There are a lot of resources online right now, a lot of organizations that provide POCUS courses that you can attend. And of course, simulators. There are simulators either sold or can be brought into the departments that can help teach anesthesiologists in training, or to enhance the faculty education for the existing faculty in the department. Learning models, the advantage of it, of course, is cost effective. There's not much traveling that you have to do. You can do it at your own pace. You can learn again some credits from these type of courses that you do online. The simulators themselves, they can teach obviously the skill set in terms of scanning and acquisition, but you still have to attend hands-on every once in a while, of course, to have the experts show you directly what you need to do. But definitely these learning online models do help tremendously. So the ASRA recommendations, they have created a list of kind of the minimum number of scans that you might want to do to reach competency level, and they divided that into the certain applications that I just mentioned in the beginning of the presentation, between airway, lung, the trauma, the gastric, and the cardiac applications. The more complex, of course, the anatomical region, the more scans you need to do to gain the knowledge and the skill set to become competent to do these skills. And as you can see, for most of them, the minimum number basically personally performed and interpreted and supervised. They divided into level 1 and level 2. Level 1 is the acquisition, and level 2 basically is the acquisition and interpretation of what you have just acquired. And to achieve that level, of course, they put these certain numbers between 30 and 50 for level 1, and between 20 up to 100 for the focus cardiac exam. So as I said, this is the level 1 and level 2 for the studies performed and interpreted, and the other one interpreted but not necessarily acquired images, but you can just interpret somebody else's acquired an image, and likes your opinion, you can help in explaining or interpreting that image. Again, these type of levels of knowledge have been derived from other associations, other medical associations that already have guidelines for the training of ultrasound. So to summarize this with the ASRA recommendations, they suggested that the first 5 to 10 exams have to be hands-on, supervised, so you can gain the absolute benefit from somebody teaching you one-on-one. And then after the learner can demonstrate the basic image acquisition and competency, the supervision can be done remotely after that. For the competency level itself, which is basically achieved after you have achieved the minimum number required for level 1 and 2, and the number required to achieve competency are not considered standard of care, but are basically the best practice for current evidence available in the literature. And this is a life learning skill set. Once you gain it, you have to try to maintain it. If you learn something today and you don't use it for the next month or two, obviously you're going to have to try to relearn it, because especially with ultrasound as a hands-on, it's very important to practice to make sure that you maintain that skill. So for the assessment of competency, knowledge examinations and multiple choice. There are multiple organizations, including ASRA in North America and ASRA in Europe. They run these type of courses and examinations that can consist of multiple choice and practical examinations. Obviously, it's very important for anybody who does do POCUS during the initial learning phase is to build a good portfolio to show that you have met these numbers, and you can continue in case you want to take specific exams like the American echocardiography exam, and I'm sure Europe has the same thing. They require you to show that you have done these type of exams, and an expert would have to sign off on it. So make sure you keep track of these type of exams You keep a record of all these tests that you have done in an Excel sheet or something on a computer that you can revert to, and you can see exactly how many tests you have done from each one of those applications. I've created an assessment competency in general for the POCUS examination, from indication, acquisition, interpretation, medical decision making, knowing the content, the training tool, and the assessment. This is kind of an assessment tool for the competency that the supervisor can look at and assess a learner whether they covered most of these points on the summarized table. They created also a checklist for POCUS, where you can cover the basics of ultrasound, image acquisition, image interpretation, and medical decision making, which is kind of the most important part of obtaining an ultrasound image. And of course, they created, I didn't put the tables in here, but they created specific checklist for each one of those applications, whether it's lung, FAST, or cardiac examination, focus cardiac examinations. The barriers basically for advancement of the POCUS education, lack of adequate equipment. A lot of hospitals don't have proper ultrasound machines, and if they do, sometimes it's old, it doesn't have a lot of features. If it doesn't have the features, it doesn't have certain ultrasound probes that you need for the POCUS examinations. And that's could be due to financial constraints from the hospital. One of the solutions could be to consider handheld devices. And one of the other solutions as well could be that multiple departments can standardize which vendor to go for to gain some of the privileges that come with it, from a discount or added probes or anything like that. What you'll be missing on, of course, is competitive products and possible better ultrasounds. I mean, you always have to look at the benefits versus what the advantages versus disadvantages of going with one company versus multiple companies. The curriculum is curriculum is basically lacking in most universities. In recent years, however, a lot of universities started creating their own curriculum and provided for anesthesiologists in training. And this is slowly getting standardized right now by these organizations like ASRA and ASRA. There are multiple variable resources online and books being published on every year, or that you can find for your learning purposes. And the other major problem with insufficient faculty and time constraints. You need people to teach, you need people to learn in order to go ahead and teach the next generation of anesthesiologists. And that can require financial investment, timing, and of course, that is needed basically for faculty development. This is a summary of all these type of barriers that you can find on the table.
Kris,
here.
we're running a little bit out of time. Can you come to a conclusion?
I just wanted to, I just wanted to mention the resources in here. You have a couple of resources between the Canadian POCUS, of course, ASRA, and last but not least, of course, the ASRA run a great POCUS program as well, led by multiple people that thankfully I know personally from Belgium as well. So that's basically it, for summarizing these couple of articles. Sorry, I went a couple of minutes over time, but thank you very much for your attention.
Thanks a lot.